Keynote's starting now, yeah.
Oh, it's starting now?
Yep, and then the town, we'll do the town hall immediately after that.
Okay.
Check, 1, 2, check. Okay. Good. Good afternoon, everybody. At the risk of interrupting the conversation, we love to see that. I have the distinct pleasure of introducing our keynote speaker this afternoon. I am going to forego her bio because I know that Mandi will tell us about herself. But I did want to just share a little bit of a story about our friendship, how we became friends. My background prior to coming into health IT was in long-term care, senior care and services, and I was in that area for about 12 years. And so when I transitioned into health IT about 4 years ago or so, I'm the marketing guy, and so I went to my social media network and immediately started seeking out people who could help me sort of get through the learning curve. And there was a core group of people, probably 4 or 5 people, really from an HIT perspective, kind of nationally known folks who very generously sort of stepped up and were very open, very willing to provide information and to help me get engaged with those people that I should be engaged in. Mandi was one of those people. About 2, maybe 3 years ago now, I forget, we had been sort of acquainted online for about that period of time, and I was at the National HIMSS Conference, and Mandi and I happened to be at the breakout session that a mutual friend was giving that afternoon, and I went up, and we had only known each other by our tiny little pictures on Twitter at that point. Went up and said, "Hi, Mandi, I'm Brian Mack," and Mandi being Mandi. Big, huge hug from Mandi, Brian. I'm so glad to meet you in person. And, we have to take a selfie, because that's what Mandi does. So we took this selfie, and we've been good friends since right through that point. And so it is a huge pleasure for me to be able to introduce my friend and colleague and really one of the leading minds in health information technology, particularly as it relates to patient care today, Mandi Bishop. Thank you.
All right. Thank you. Thank you so much, Brian. And he's right, I do have a bio slide really quickly. How many people in this room had heard of me prior to this moment? I mean, you saw me on the agenda. Okay, Pete, nice. So my feelings aren't hurt that it was not a lot of you. Unless you are very active on social media and unless you travel in the very wonkish circles in which I generally find myself, it is not likely that we would have come across each other. I have not spent very much time here in Michigan. The last time I was in Detroit, I flew in and out for a day. I was part of the Blue Health Intelligence Data Warehouse build about 10 years ago, and stage 1, kind of the place for that occurrence was Blue Cross of Michigan. So I came in for a meeting in Detroit 10 years ago, in and out for the day. This is my very first opportunity to spend an evening here in Michigan, and it is beautiful. So thanks for having me. I've been doing big data since before big data was cool. So I helped build the National Data Warehouse at the Blue Cross Association. I was involved in the largest claims asset at the time. So this was 5 years, 50 million lives for the Blue Health Intelligence Data Warehouse build. I've worked all along the care continuum, so I don't know if you want to say fortunately or unfortunately, my experience spans from independent general practitioner's office through very large integrated delivery networks, through claims clearinghouses. I built some of the first clinically integrated networks. I built private health information exchanges. I worked with organizations to build initial clinical data exchanges back before HIE had been coined, before this became a thing. And I'm very passionate about the fact that we all need to keep in mind healthcare exists for the patients, right? The story of healthcare and our industry exists because we are here to serve patients. And so as we are building out these data stories and as my career has begun to take off and expand, and I have an opportunity to influence people in our industry, I always try to keep in mind that the story is about the people. Healthcare is about people. This is who we're here to serve. The talk that I'm giving today is not the talk that I had written. So the talk that I had written changed last week, and we're going to go into a discussion of why. I'd planned to talk about this type of unicorn in healthcare. So I'm assuming everybody, when you read the title, I thought that the title was fun, the HIE, the unicorn use cases. How many of you pictured like a Theranos or a Silicon Valley type scenario? Anybody? No, that was what I was thinking, right? Everybody wants to have the unicorn. We all want to be able to find that new multi-billion-dollar opportunity. The entire healthcare transformation space is about finding this new multi-billion-dollar opportunity. Here in Michigan, one of the things that I'd planned to talk about, of course, was Flint. I planned to talk about all the ways in which HIE may have been able to find those lead poisoning clusters years earlier, right? Had we actually had a more effective adoption and use of HIE. Could HIE be used to drive behavior modification? We all know that that's what's going to win the war ultimately on healthcare transformation. Behavior modification, personal accountability, and responsibility. But instead, I'm going to talk about healthcare's human unicorns. This is the 1% of the patients who drive 20% of the cost and an inordinate amount of the utilization. So if you guys can humor me for a minute, if you can close your eyes and picture for me what this human unicorn looks like for you. And I am actually going to call on somebody to have them tell me what's in their mind. What do you think of when you think of this person, this patient, who drives such a substantial amount of the cost?
Complex, chronically ill patients.
How old?
Could be children, could be any age.
Okay, that's actually a really good answer and surprising. I expected, because usually when we talk about these people, we talk about them kind of in terms of end-of-life care, right? We think about they are chronic and complex. I know for myself, I typically picture a geriatric patient. I typically picture an elderly patient who is aging in and having, acute event after acute event after acute event at the end of life. But instead, we're going to talk about my friend, Jess Jacobs, who passed away last Saturday at 29 years old. She isn't someone that you would picture, I don't think, as one of those human healthcare unicorns. Clearly, she was incredibly vibrant, just a beautiful human being inside and out. Her inner beauty shone through. And she was part of our unicorn squad. So it just so happened that I had aptly named this talk, right? So she is a human unicorn. She was a healthcare insider. So Jess Jacobs had been a director of innovation at Aetna. She started her career as a fellow at the FDA. She had been an O&C policy analyst. She worked very, very closely with Dr. Farzad Mostashari, the very first national coordinator of the O&C. She wrote HRSA's Text for Baby protocol, and she was a White House policy advisor. Jess was incredibly well connected. Jess knew the system inside and out, but Jess was a chronic patient. She had 2 rare diseases, EDS and POTS. She also had cyclic vomiting syndrome. And then she had a number, of course, as all of these patients do, right? There were a number of additional complications that arose from these chronic conditions. She began to have pulmonary embolism after pulmonary embolism. She began to have difficulty, with all of the facets of her daily life. Part of the POTS and the EDS was fainting. So she began to have support, people to follow her around and make sure she wasn't going to fall. Obviously, this impacted her daily life, but she was able to continue working very passionately within the healthcare industry all the way up until the end. But caring for Jess, even as an industry insider, was incredibly challenging. So when we talk of clinicians, beyond those clinicians, she had a team of first responders. And those first responders were her friends who were also healthcare industry insiders who lived in Washington, D.C., where Jess lived, who were able to come at a moment's notice and help her with transportation to a hospital, or help her transportation from a hospital, help her with her numerous clinician appointments, help her navigate the healthcare system when she was too exhausted to have to continue having conversation after conversation ad nauseum with the same set of 6 hospitals and any number of actual doctor's offices that she visited on a regular basis. Beyond those clinicians and the first responders, Jess had an extended social watch team. So I was part of her extended social watch. I did not live in DC. I'm from Jacksonville, Florida. It's a little bit far for me to go and try to pick Jess up and take her to a doctor. But there were signs that we could watch for. There were indicators that Jess was about to have an episode. There were things that she would say on social media, and there were things that she would say privately that would let us know in her extended circle that she needed help. And then we would go back to those first responder teams and engage those first responders to assist Jess and to try to help her navigate this system and to try to help her experience be better. In order for us to effectively manage Jess's care, we needed HIE. HIE is fundamental, right? It's fundamental for all of our value-based care methodologies. It's fundamental for all the new reimbursement models that are coming out. HIE is a noun and a verb. There are various definitions for how an entity is going to represent HIE, but it shares a common goal. Longitudinal medical records securely shared and accessed in a timely manner. Fundamental for care for someone like Jess. This was Jess Jacobs' health information exchange. She had a series of binders that she carried around at all times that contained her complete medical record. Can you imagine walking into a doctor's office carrying 3-inch thick 3-ring binders and telling them that this is your medical record. This is every lab result, this is every medication, this is every encounter that you've ever had. And as a patient, having to explain to that particular doctor on that particular day how all of that was relevant to this 7 minutes that you have to spend with this physician. I know that my medical records aren't this thick. Beyond these binders, and because of even within HIE, when we think about it today, the why for a diagnosis, the why for a prescription isn't there. That information isn't contained. And so if in the blink of an eye you're having to explain to a hospitalist why a hematologist at a competing institution prescribed a particular care pathway, Jess was clear-minded enough to actually record all of that information. She had chart after chart explaining and mapping out the why for every single one of the diagnoses that she could get an answer for, and for every single one of the medications. But this was her HIE. And in order for her to be on a pain management contract, she was required to get all of her health records, and she was required to produce all of her health records within 1 month of that pain management organization asking for it. So again, making a case for electronic HIE. How is the patient responsible? How is the patient to enforce that 30-day time frame, right? The OCR has only recently required that 30 days and clarified that your complete medical record must be made available to you within 30 days. But yet for Jess to sign a pain management contract, having her complete medical records and being told that she has to produce it within 30 days of being asked was a requirement for her to enter a pain management organization, to enter a pain management plan. She was really, really funny. Jess was hilarious. And she posted a lot of this. You'll notice all of these things are on Twitter, and this was one that really resonated. Her personal health record was augmented by her Twitter feed, right? She had a doctor that couldn't find her last pulmonary embolism. They didn't have a record of her last pulmonary embolism. And so Jess was able to look at her feed and say, okay, well, I made this meme exactly a year ago today. So somehow my personal health record, which now extends, if we think about health data, this is kind of an expansive definition of health data to include her social media data. But her social media data was relevant. This was part of her personal health record, and it was more accurate than the information that was contained in the EMR. So Jess, as the patient, knew full well what treatment she had received and when she had received it. So Jess became her own best advocate, and again, expanding upon this HIE of one, going beyond those binders that she carried, she leveraged the digital space as her own personal health record. But it's sad that she had to do this. And it's also incredibly typically going to go in and do a full med rec within the EMR for those 8 pages because nobody's got time, right? That's not feasible the way that our system works today. So Jess's own records and Jess's own diligence in her medical reconciliation or medication reconciliation was critical for keeping her alive. She was a huge fan of meaningful use. And I say that in all seriousness. She was an incredible fan of the opportunity for meaningful use. And she was on board with HIPAA privacy. What she wasn't on board with were patient portals. Especially patient portals that, for someone like Jess, for complex disease states, having patient portal after patient portal after patient portal, that hyperportalitis, and so if Casey Quinlan is watching, I'm tapping Casey Quinlan to let her know that I tried to use hyperportalitis in a sentence. But the disease of having 20 different portals with 20 different login criteria to try to reconcile a single patient, medical record, it wasn't feasible. So what she did was had all of her records emailed to her wherever possible so that she could then print it off so that she could reconcile. So although her friends carried paper HIPAA releases that allowed her friends to access her record and to speak with her providers about her care, frequently it was denied. Frequently that level of access was denied. There was a lawyer. The hospitalist wasn't aware of the clarification of the rule. There was always concern. We are so afraid of litigation that it impacts our ability to be human and to care. So what if her team could access an electronic health information exchange? What if her team could have shared the records that were appropriate via health information exchange? And what if her team could search encounter data and identify records that were relevant, that would have been helpful? This is where we need to go. Talking about education, I know I receive an education pamphlet because meaningful use requires that I'm sent an education pamphlet, right? Every time that you click through an EMR and a particular diagnosis is identified, there is an educational pamphlet that's assigned, and this is the way that the government has assigned us our educational priorities. Jess Jacobs didn't have heart disease. Jess Jacobs had POTS. It was very different, and she was very funny about the way she articulated the differentiation between heart disease and POTS by letting people know it's not really, she gets more heart tests as a result of having POTS than, in 1 year than most people get in a lifetime. So the likelihood that she would have an event that wasn't caught is significantly lower, right? Substantially lower than it would be for another woman, right? Because we are higher risk of heart disease. Education relating to Jess's actual illnesses wasn't provided to her, right? Because these are rare diseases. Education about all of the possible complications of her multiple chronic disease states wasn't available to her. And she encountered a lot of patient safety issues. Again, Jess being a highly educated, highly involved patient, Jess would go through the number of medications that were sent to her. She had mail order pharmacy, as I would imagine was much more prudent for her to do, given the number of prescriptions that she was on. And in this particular case, 14 out of 23 items were, if Jess weren't on top of her medication reconciliation, if Jess had accidentally taken the things that were supplied in that box, because that was the directions that were provided, Jess would have died much sooner. She faced a lot of very awful conditions in the hospitals as a result of her treatment. Things like nurses leaving the IV prep work on the floor. They would leave the tubes on the floor and pick them up from the floor and insert them. Jess had a central line. Nurses would be putting her central line in, and they would take a page They would touch their phone, and then they would return to putting the central line in. Things like that Jess was very qualified to identify, right? She knew that these were patient safety violations. Many of the people who were watching after her as part of Team Jess knew that these were patient safety violations. They weren't addressed. They were brought up. Jess was very articulate. Jess was very, very clear. The things that she shared publicly were not named, right? She was very conscious of the fact that in order for her to serve the greater community, she could not go to war with an individual institution because she faced these types of issues at every single one of the institutions that she visited, and she went to them all. But behind the scenes, Jess knew the administrators of these hospitals. She knew people who were in positions of power to make, to affect change. But unfortunately, change didn't come. She did a lean analysis of all of the time that she spent in the healthcare system. 98% of the time in the last 2 years that Jess spent in the hospitals was considered waste. So she was a Six Sigma green belt, not a black belt, Six Sigma green belt. She had lean training, and she obviously was just very, very conscious of wanting to maximize the amount of time. She knew she did not have infinite time on earth. She knew that her time was shorter than many. 98% of the time that she spent in the healthcare system the last 2 years of her life was wasted. How on earth was she supposed to get that IV stand through that bathroom door? How is that supposed to happen? That's a design flaw. Beyond being, this is not necessarily a health information exchange flaw, that is a design flaw. Again, these types of things Jess was observant of. Jess would take note, and she knew the process. This represents the actual first time that she filed a complaint. So the IV represented an ADA complaint. She was not able to effectively use the restroom because she's a provider in her continuum of care to have infinite knowledge about all of the complexities of the drug-drug interactions and even the condition interactions that she had. She knew that it wasn't feasible for one doctor to have all that information. But if all of her information had been stored in an HIE, and if the analytics on that information could have contributed to a clinical decision support application, right? What if we could have done that? What if we could have suggested education based on the analytics of her condition? What if we could have personalized that education delivery so that it actually spoke to Jess and so that it was relevant to her experience? What if HIE could inform grand rounds? So right now, Jess actually took time out, even though she spent so much time in the hospitals. She took time off work, additional time off work, to participate in grand rounds in some of these facilities that had caused this harm. And what if we could do grand rounds with HIE data? No talk about health information would be complete without talking about authorization. How many insurers do I have? Anybody? Anybody from a plan? Not a single person. Oh, good. Okay, yeah, there are a few. You guys didn't want to admit it. It's all right. I've worked with insurers for 10 years. I love. Yeah. Okay. Kind of. It's one of these. Like I'm just kind of gonna raise my hand to early raise. I think that universally the authorization process is despised. I don't think that insurers are unique, right? I mean, authorization is terrible. Authorization is a black box process that no one understands. The medical review board rules are not broadcast for anyone to know. So it's necessary. It is a necessary evil, but it's completely hidden from the rest of the world. And imagine what authorization looks like. So when I'm saying authorization, I'm using a blanket, right? So I'm talking about the referrals, the pre-authorization, the authorization, pre-certification. Imagine what that looks like for Jess. So this is what her paperwork looked like after she got out of a 6-week stint in the hospital. This is just 6 weeks worth of papers. The stack on the right is 3 inches thick. There are deadlines around authorizations. There are very strict and rigid protocols that one must follow in order to have procedures authorized, and in order for insurance to pay, and in order for you to appeal a decision, whether it's an internal or an external appeal, they all have deadlines. So if you have been in the hospital for 6 weeks, you missed your 30-day appeal deadline if you have to appeal a claim from the last time that you were in the hospital. You've missed it. And then you're already going into your 60-day cycle for your external review. And if you have to go into the hospital again, you could miss that. So ultimately what ended up happening with Jess, none of these got paid, right? You know, there's a vast majority of the things that were not able to be authorized because God knows Jess was so sick that she could not connect the dots from her hematologist to her, her ontologist, to her gastroenterologist. To, for her to be able to connect the referrals and the authorization dots and jump through all of the paperwork hoops that were required for her care, given how sick she was, it was not feasible. Even with an army of people who were all healthcare industry insiders, it wasn't feasible. The entire team Jess wasn't able to tackle this paperwork. Not to mention, half the time when she was going to the hospital, she wasn't coherent, right? So if you're trying to choose an in-network hospital, I always love the in-network ambulances, the in-network ERs. How the heck are you supposed to go and be financially responsible about your in-network and out-of-network choices when you're unconscious? How are you supposed to inform those doctors about your prior medical records? HIE definitely can help with that. I think this is the biggie when it comes to the business case from a unicorn standpoint. I think HIE could be used to disrupt authorization and certification. I think insurers could use HIE data to automate these processes, but this would require a significant culture shift from the insurers. We would have to take all of that processing, all of the medical review board rules, they would all have to come out of that black box of eternal darkness, and they would have to not just be rigidly applied, but they'd have to be system-level business rules. We would have to be able to push decisions through in an automated fashion across a much broader care spectrum than we have now, right? There's a narrow window right now for pre-authorization, pre-certification to go through automatically, but it is very narrow. And in cases like Jess, where it's incredibly complex, typically doesn't apply. So what if we could use the HIE to completely disrupt authorization? How much time would that save all of us in this room? And how does that time equate to the cost, right? Billions of admin costs saved. And beyond the billions of admin costs saved, how much time and how much stress and how much quality of life does that save for each of those human beings who is going through this process? At the end of the day, it's all about the person. So every time that Jess had an authorization and a claim denial, every time that she got another bill that she couldn't pay, that's additional stress on an individual who was already incredibly sick. This is a real opportunity. So even with everything that Jess went through, she was always smiling. I don't understand how she did to feel better and to trust the healthcare system and to trust that process, to trust the IV insertion and to trust the nurses and doctors who are going to be working with those children to place a central line, because that is scary. So Jess started with one of these unicorns, and then she created kind of a stable of Port Petty unicorns, and they were all donated to Sibley Children's Hospital there in DC. And more importantly, she gave concrete instructions constantly about all the ways in which it could be improved and it could be better. She told us all the time. She told us on Twitter. She told us on Facebook. She told us on LinkedIn. She told us through blogs. She told us in person. She told us on the phone. She told us via letters that she wrote to her providers and to her insurer, who happened to also be her employer. She gave us very specific instructions for ways that we could effect real change. And it wasn't followed. Jess was chronically ill. She had rare diseases. Healthcare could not keep Jess alive. But we can learn from her life, and we can learn from the experiences that she had in the last 2 years of her life. In death, she'll finally be heard. So we have to do better. And it starts with doing something. I'm hoping that that means, does this, do you see ways in which some of these pieces of the story could inform your organization's behavior or things that you consider doing in the next year? I don't see any hands raised. I'm very hopeful. Hi.
Hello, thank you for being here.
Yes.
I'm wondering, with the last thing of doing something,
Yes.
and with all the stuff that's being done out there, what are the top couple things that are encouraging to you that actually you think have meaning in what's being done rather than perhaps just stuff that may not result in much?
So I think there's what's being done at the macro level that is very encouraging, right? So what's being done at the macro level, MACRA, MIPS, kind of a drive towards interoperability, and we, now we have our 10-year interoperability plan. At the macro level, I think it's encouraging that we are finally understanding the problems that lead to these types of experiences must be addressed and must be changed. But then when you boil it down to the micro level and to an individual patient like Jess, she didn't have 10 years, right? So beyond the regulatory environment that's shifting to try to include value-based care and to try to understand all the various definitions of value, Andy Slavitt from CMS has been very supportive of alternative innovations, right? As part of MACRA, he is supporting identifying new definitions for innovation and how could we achieve value-based objectives without strict adherence to the latest and greatest EHR technology. That's encouraging to me because I don't think that innovation comes from technology. I think that technology enables, technology can be an enabler, but allowing people to innovate and address that micro problem, solve the problem for one patient, that's encouraging to me that our leadership, the leadership of HHS and CMS and the ONC are all kind of creatively aligned on that.
Mandi, what's being done at the very source of all of this in terms of medical schools? I mean, in my mind, we're taking care of it, as part of the health care that's being delivered, but it's the people delivering the care that are starting out in medical school. What's being done at the school level to move this process along? Because without that, you get a group of doctors that
Nutrition, right? So taking all of these additional life contextual factors into account. But it does. You're absolutely right. Medical education is very focused on diagnosis and prescription, right? And this type of holistic treatment of the patient as a human being. Ted Ayton wrote, I'll make sure that you have these slides. I think that they'll be available. But if you Google Jess Jacobs just in the last week, Ted Ayton, who is a physician, wrote a very compelling piece about the medical education not my problem syndrome and the fact that Jess is a victim of not my problem syndrome. And unfortunately, it's pervasive. So, much like our attitude about sharing health and health data, and providers overcoming their want to shut down clinical notes, like not sharing the notes, like being able to overcome that cultural hurdle in practice is now also happening in medical schools. And some are more progressive than others, but I'm hopeful that we will see a tide turning in the next couple of years. But you're right, it does absolutely need to be addressed in medical school.
Hi, Mandi.
Hey.
As a licensed counselor and also working for the HIE, one of the frustrations is being able to have medical and behavioral health all together.
Integrated, yep.
What are you hearing of any changes along that line, your perspective, and again, just kind of what are you hearing?
Sure. There are a number of initiatives in place, and of course, the behavioral data becomes tricky because from a regulatory environment, legislative environment, we have made it very, very challenging to share behavioral challenge by this complex regulatory environment, like at the legislative environment. I think that the more involved HHS has been, and there are some challenges, like Susanna Fox has been a wonderful leader in trying to get HHS to the fore of thinking about mental health. And I think that, again, the tide is turning in that direction. There's definitely a focus on it, but we have to be able to address all those legislative challenges and sharing the data and making it, making people understand that it is a right. You have just as much right to your mental health data as you do to your actual health data, and the behavioral data can inform your clinical care pathway. But not, the viewpoint is there from some leaders in the industry, but it is not universally accepted yet. I wish it were so. So I think that that's probably one of the key leading indicators for your health, right, is your mental and behavioral state.
Some due to mismanaged care. At the same time, one of the things I learned from your story last night was that Washington, D.C. Isn't necessarily in the same place as Michigan. And could you talk a little bit about where we are compared to the rest of the country? Because
Sure.
it can get kind of sad thinking about the challenges we face in healthcare and in interoperability. But Michigan is well placed, and I think that we maybe end on a little different note.
A little high, on a high note? Okay.
Just a thought.
everybody gets. Michigan, in the fact that you have such really well-established regional HIEs here, right? So you've got West and the East, and the fact that you're doing, especially here, right, the GLHC has both a direct and a query-based, already puts you ahead of the curve here in Michigan. And I do believe, especially if we were able to get EHR partners to kind of remove some of the HL7 outbound interface cost constraints that I'm sure are problematic in getting more providers connected to you, right? If we were able to remove some of those cost constraints on access, I think that Michigan is incredibly well positioned to have a true regional HIE that could effectively manage care coordination for residents of these areas. DC is incredibly segmented, and they are still, most of the hospital systems that she was dealing with were still kind of the academic institution mindset, where they have their proprietary information, they have their proprietary data, and there are a lot of obstacles in sharing that out. And so that you guys are a much more advanced HIE environment here. So I think that if there were an opportunity for someone like Jess in this environment, that you guys are much better positioned to be able to supply the information that would be critical at the right time. Awesome. Thank you guys for listening to my story about Jess. I really appreciate it. It's important, and I hope that you remember it, and I hope that you carry some thoughts about the story and about the ways in which you and your organization could affect a real change, even a small real change, with what you heard. Thanks.
Awesome, thank you. We are actually just a few minutes ahead of schedule, which just plain doesn't happen, which is terrific. So I'm going to suggest that maybe we take a few minutes break, and that'll give an opportunity for the GLHC leadership team to come up and get their microphones in place. The next session is again back here in this room. It's our town hall meeting, and it is also the audience participation portion of the day's events. So this is the chance for you all to bring your questions about any aspect of GLHC as a business, as an organization, about what we're doing. We have some questions that were submitted to us electronically, but there are cards on all of your tables. If you would like if you'd like us to handle it that way, then feel free to jot something down and bring it to me. But we will also open the floor to your questions as well. So the leadership team will join us at 1:15 exactly, so plan to be back here at that point.